Dr. Christopher Gardner-Thorpe has been a patron of the Devon and Cornwall Lupus Group for over 15 years, during which time he's given us great support, attending our meetings, chairing our AGMs, and being a regular speaker. Our members appreciate his warmth, wit, knowledge and experience. I regularly hear the comment after one of his talks, "He had us in the palm of his hand." Christopher trained in medicine at St Thomas's, and then in neurology, holding the post of consultant neurologist at the Royal Devon and Exeter Hospital, and working now as an independent consultant neurologist. He's a wide interest in neurology, including the manifestations of lupus within the nervous system. He also has commitments in teaching medical students at the Exeter University Medical School, mainly in humanities, medical history, medicine and the law, and medical writing. He's a former president of the Faculty of History and Philosophy of Medicine and Pharmacy, and currently examines and directs the courses in medical history at the Society of Apothecaries, a livery company in London. Today he's given his talk the intriguing title, The Doctor's Dilemma. And I know you'll find it interesting. Ladies and gentlemen, Dr. Christopher Gardner-Thorpe.
Thank you very much, David, for a really lovely introduction to which I'll try to live up. Thank you. It's great to be here again and to meet lots of people who I've met before, so it's a real privilege. Now, when David asked me to speak a little while ago, I did what I usually do, which is try to devise a title to which I could speak really on a variety of topics, and this is the title I chose. You'll note the apostrophe has been moved to after the letter S, implying that this is a problem that doctors in general have rather than a particular doctor. And I'd like just to meander around some areas, and to start by showing you this picture of George Bernard Shaw, who of course wrote the famous play called The Doctor's Dilemma, which highlights a lot of the inequalities in health and difficulties which beset the practice of medicine. Now, the first one that I've just mentioned is waiting lists, which is obvious to everybody, and the difficulty with managing waiting lists for doctors in general practice and in hospital medicine is the issue of equality. And the question is, how best can we address this? There's a famous name, Jeremy Bentham, who, in philosophical terms, as a philosopher, really promulgated the idea of the greatest benefit for the greatest number, which I suppose is what we all try to do, really. But the question is, how do you rank the issues in front of you so that you can try to achieve that? This is Jeremy Bentham sitting in his cubicle at University College London, and he's visible from time to time when the front mahogany doors are opened, as some of us have seen. The issue really becomes one of triage, and this is a picture from the First World War of a triage station during the First World War. And the principle of triage, I suppose, is one we try to apply. We try to say, do we not, that everybody needs treatment, everybody deserves to be treated the best way possible, but when resources are limited, how do we actually put people in order? And one way of doing that is to say first come, first serve. But triage really, of course, implies that you divide people into three groups. You want to treat first those for whom you're going to have the greatest effect. So back a little bit to the Jeremy Bentham philosophy. There's no point in terms of resources in trying to devote all the resources to those for whom you will make no difference whatever. I'd just like to qualify that, because doctors, nurses and other healthcare workers, and we're going to hear a bit later I think about other healthcare systems, there's always something that we can do. They say to try and comfort always. There's always the possibility of discussing problems with patients and trying to minimize the problems. So triage in that sense is a little bit difficult if you're going to say that you can't do anything for somebody. You can always do that, but if resources are limited, for example, if you're going to try and stop bleeding ahead of doing something else, then that obviously takes priority. So triage is three groups. It's the group for whom you will make a difference if you do something, the group for whom whatever you do, there's not going to be much change, and the third group. So that's triage, and that was introduced by Napoleon surgeon Larry in the 1850s. Here's a picture of Larry. Are these pictures showing all right?
Yeah.
Probably are. Can you hear me all right? I usually try and ask that question to begin with, but I forgot. Do sing out if things drop. The issue of private work is politically a very sensitive issue, though things have changed a bit in the last 10, 20, 30 years. The question is whether healthcare workers, and indeed others, lawyers and many in society, should be able to advantage certain groups of the population simply through their financial ability. This is a very tricky area, and of course governments recently have tended to farm out a lot of NHS work to private hospitals and private systems, which is surely good. So, in fact, all these private facilities are capable of being used for the benefit of people who are funded through the healthcare system. It's a very tricky area, and it's one that over the years has promoted an awful lot of discussion. And it's difficult to know exactly where the answer lies. But another area which has arisen, and it's very topical now, is the withdrawal of labour. The issue topical this week, of course, is the issue of pension contributions. Now, I'm not a politician or an economist, but you will have read of the difficulties of those who take on lots of extra work, or even a little extra work, who in fact suffer financial loss through doing so. And this is a balance really between the so-called vocation of medicine, where you're trying to do something decent for people. And when I say medicine, I mean nurses and all the other healthcare workers too, on the one hand, and the ability to be employed satisfactorily on another. So withdrawal of labour is a very difficult issue. And I'm talking about dilemmas, I'm talking about situations today where there isn't necessarily an easy answer. So I'm asking questions more than providing answers, but there may be questions from others later, which I may not be able to answer. Charles Dickens, of course, wrote quite a bit about these sort of problems. Here's a picture of Dickens, a famous picture. He's unmistakable, isn't he, really, with his ragged hair, like I have, and beard, which is quite characteristic too. And he wrote in his publication Household Words, which I'm not suggesting you can read here, but here's a couple of pages of it, about the discrepancies in medicine. And he was very critical of the work of doctors, particularly of apothecaries. And Alison has, or David referred to apothecaries. The apothecaries is a livery company in London, as many will know, which used to license doctors until the GMC, General Medical Council, took over in the 1850s. And it has a wonderful hall, of which this is a watercolour painting in Blackfriars Lane. And it now issues diplomas, runs courses, and you've heard mention of the history courses that I'm involved in, as well as providing other diplomas necessary for practice, actually. And there's a big conflict and catastrophe section as well, with a long waiting list where people go and discuss the issues of going abroad to try and help in medical and sociological terms where there's a crisis in the world. Very dedicated young people. At the back of the apothecaries is Playfair Yard, shown here, and this is actually where Shakespeare used to play, and this is a picture of the Globe, just to remind us. So this company is important, and this is a picture of Hans Sloane. Now, Hans Sloane is standing here in the Chelsea Physic Garden on the embankment of the Thames in Chelsea. Hans Sloane brought milk chocolate to England, we're told, and his name, of course, is well known around Sloane Square, Sloane Street, the areas I used to knock around when I was living in London as a medical student. And he's in the middle of the Chelsea Physic Garden, shown here with some nice specimens, and here with another. And the apothecaries, of course, used to use a lot of plant products for treating patients. And many of the drugs we use these days are actually derived from plants as well. The vinca alkaloids are a good example. The anti-mitotic, anti-carcinogenic drugs. And here's a picture of the basement of the apothecary's hall, which shows the manufacturing place where, until about 1950, many drugs were still being manufactured. The manufacture of drugs for the army and the navy, particularly in the 1800s, were manufactured here, but that has now stopped. And this livery company is now a place where there is collegiality, it's a club if you like, a dining club as well, but somewhere that actually issues diplomas useful for medicine. This lovely little building in Duke Street, around the corner from Selfridges, is actually a homeopathic pharmacy, beautifully mahogany shelved inside and so on, showing that in fact products which are not necessarily produced by the big pharmaceutical companies are still in use. And this has been an area of medicine where there's been a lot of debate over the years as to whether or not what one might call orthodox, but that's probably not the right word, practitioners who we regard as medical practitioners who treat us, were censured really for making liaisons with other practitioners, particularly chiropractors, osteopaths, homeopaths, people in areas where it was not understood by what I called orthodox practitioners what actually was being done. And homeopathy was one of those things, but of course it's risen in popularity recently, not least through Prince Charles's promulgation of the idea. So to what extent should healthcare workers dissuade patients from using remedies which they think, which the patients think are proving helpful? And the answer is that very often the unexpected happens. Things which are not perhaps accepted as a standard form of treatment help some patients. And it's very important for practitioners to try to encourage people to do what is going to help them best. So that's homeopathy. And this might be homeopathy too. This is Durer's representation of a rhinoceros from the 1700s. It's not a very good rhinoceros because it's got all sorts of armour plating on it, whereas rhinoceri have Greek rhinoceres do not. But you'll notice the horn too over the shoulders, if you like, above the front limbs. It's said that Durer never actually saw a rhinoceros, and this was his idealised description of depiction of such. Another issue which has hit the headlines recently is that of compulsory measles inoculation. It's current this week, isn't it, and last week and before. This is the name of Edward Jenner, Jennerian vaccination, and his dates in the 17 to 1800s, and here's a picture of the man. I'm afraid some of these pictures are not terribly good because they come off the internet, but I think at a distance you probably are finding the pixels fuse all right. Jenner was the describer, of course, of Jennerian vaccination, inoculation against smallpox, a real killer in his time. And there was great debate in church terms about whether or not it was appropriate to expose people to the risk of vaccination. And the concept of herd immunity, H-E-R-D immunity, is very important, and that's the argument which is being used by measles. That if you can eliminate a disease from sufficient persons within a community, then the risk of somebody else getting it gets much smaller. So there's an argument that we should all be inoculated against various things in order to reduce the incidence of that disease in the community. You might argue that shingles and flu inoculations and so on are cases in point, but those conditions are less troublesome than measles. Hence the argument that there should be compulsory inoculation against measles again. And the real criticism of Andrew Wakefield and his work, who was said to have promulgated a view which was not appropriate, namely that the measles inoculation combined with two other inocula actually led to various other problems. He's been rather discredited in the press about that, and the ability to try and reintroduce inoculation against measles is a very important issue because of herd immunity, let alone the issue of individuals getting the disease. It really is a very nasty disease and it kills people. So this is one of the dilemmas that doctors have too, and politicians, and economists, and all of us in fact. I thought you might like to see a depiction of Jenner's microscope. Here it is, which used to be in Gloucestershire. I'm not sure where it is now. I went to see it about 30 years ago, and it was Jenner's microscope, and it was also passed on to James Parkinson as a disease, of whom more in a moment or two. Vaccination, of course, against smallpox comes from Vaca, a cow, and this is a French depiction of a French cartoon of inoculum being obtained from a cow. And here's a picture of Jenner inoculating a boy, and another depiction of him inoculating probably James Phipps, who was the son of a dairymaid. There's a long story about inoculation, which we could promote, but won't today, of course. But that's not the only disease, is it? When I was travelling around South Wales from time to time with friends there, I stumbled across Tredegar, and I learnt that there was a little graveyard up at the top of the hills in Tredegar. And this is my rather poor picture of it. It was made on a colour slide and then scanned, so I must go back and do it properly, with all these tumble-down tombstones, of which this is one, mostly the Griffiths family. And this was a cholera graveyard. And when I showed these slides and talked about it once sometime before, somebody said, well, I was a young girl there. When I was at school, I was told not to go up there and play in that graveyard. Here's an illustration then of a different disease. And Aaron Devon, who formed the health service really, grew up in Tredegar, in school there, and his picture here on the right is matched by the rather nice statue which is opposite Cardiff Castle in Cardiff. So there's a big issue about inoculation and how to treat, about herd immunity, about the ethics of actually injecting substances into people in order to try to do, try to do some good in prevention of disease. A dilemma, something to talk about. Another dilemma is that of diagnosis, and I put the word lupus under it because it is really very difficult, as everybody knows, and sometimes it takes a while to reach the right diagnosis, and I'm looking forward to hearing Graham Hughes later, who I know will elucidate much of this. This is a picture of a book about Gilbertus Anglicus, who was around in the 11 and 1200s, and who was one of the earliest people from whom we have some writings about medicine and therefore medical history. And this is a picture of Boerhaave from Leiden, a place where many doctors, including some of the earliest physicians in Exeter and elsewhere, a place where he taught, and he was called the educator of Europe. This is a picture of the house of James Parkinson in Hoxton in London. I mentioned James earlier. And the relevance of this is that some diseases are very easy to diagnose, and Parkinson's disease is one of those. Not always, but usually, it's what we doctors call a spot diagnosis. In other words, it's made on the basis of what the patient tells you and what you observe in the patient. And indeed, Parkinson described some people walking across the street opposite him, so some of them were not even his patients. That's sometimes easy. A diagnosis of anemia or diabetes is easy too, because you have set criteria. If your hemoglobin is below 10.5, you've got anemia. If it's above, you're not. It's a matter of definition. But lupus, of course, presents real problems, so we'll hear about those later, I'm sure. Just to show you the sampler which Parkinson's daughter sewed, and you'll see, you probably can't read on the bottom, she said education serves the, I can't even read it either now. Anyway, she was talking about education. Education forms the tender mind. Yes, thank you very much. Yes, yes, thank you. Yes. So, learning and teaching are important, and here's something which Nietzsche wrote. Something the doctors need to continue to do, to learn, and this is something about history too. So teaching and learning are a very important dilemma for doctors and other healthcare workers too. And it's the way in which the medical school here started off was saying lifelong learning is important, and that's true for all of us. However, Carl Jung, the psychologist really, wrote this, which may be right. It presents us with opportunities and with thoughts as to how to behave and what to do. Here's a picture of Jung. There's a very nice interview with him, by the way, on YouTube, which is quite entertaining. However, this is what Aldous Huxley wrote, which seems to me quite pertinent. So, what do we do to try and keep lifelong learning? We do bits of research. And Charles Scott Sherrington is a man known to neurologists, like Nick in the front row and me, as a physiologist. Here he is. And he did a lot of work on the transmission of nerve impulses. And he wrote this about teaching. Meaning really that we should learn to learn, rather than learn by rote, rather than learn facts and spew them out again. We should learn to judge and make decisions. Charles Darwin, of course, helped us make a lot of decisions. Here's a picture of Charles Darwin. And the genetics which has followed this has presented a lot of problems in diagnosis too, because it leads us to be able to predict, to some extent, disease processes that are going to occur in some diseases. Huntington's chorea perhaps being the most famous difficult diagnosis. And the question then is, to what extent one can discuss with patients what the risks are and what decisions should be made. And there are also real problems there when insurance companies want to know what the risks are. And that's another long debate, which I haven't got time to enter into. Aristotle, all that time ago, said this, and indeed it's true, is it not? Transplantation has presented a lot of difficulties, and nowadays intrauterine operations, last week, wasn't it, an intrauterine operation for spina bifida on a baby. To what extent is it okay to do these things, see what the results are? I remember when I was training at Thomas's, doing a short stint on the surgical unit where very early cardiac surgery was carried out using the heart-lung pump. And I remember that people were coming off the pump, they were being operated on and then recovering, but they got some brain damage, some of these people, because of the bubbles which came from the pump. A really difficult problem. And if it hadn't been for that early work, which wasn't, I didn't contribute anything to it, sadly, wish I had. If it hadn't been for that early work, then modern cardiac surgery would not have developed, probably, in quite the same way. But, of course, the ethics of this are very difficult. If somebody has irrecoverable disease, something you can't do anything about, except by creating risk, what do you do? What do you decide? Well, the ethics of this are such that you discuss it and say, these are your options, these are the risks. Do you want to take the risk? Another dilemma for doctors, and a real dilemma for patients too. And when I say doctors, I mean all healthcare workers, I keep saying it. There are myths too, which make things difficult for us. And this anonymous comment, he was very prolific, actually, wasn't he? He wrote a lot of things. And I mentioned the name of Charles Bell. Bell's palsy, Charles Bell, a surgeon in Edinburgh and at the Middlesex, and here he is. Because he described a palsy of the facial nerve, shown here, Bell's palsy, facial nerve palsy, and he said in one of his works, this upset a patient of mine who was travelling in a carriage with the window open, and from that probably has developed the myth that if you're in a draft, you get a Bell's palsy. We don't believe that now, but it's a myth, and we have myths in medicine which are important. Bell did a lot actually in neuroanatomy in describing the brain, and here's a little bit from one of his publications. Well, living to tell the tale, this is Marques's comment, which seems to me important too, and Oscar Wilde, the cynic, said this. Well, what we're trying to do is look backwards, aren't we, and forwards. We're trying to look backwards to see what happened, how it can inform us, to use that modern verb, as to what we should be doing now, and look forwards to what we should do. And back to rhinoceroses, rhinoceri, whatever they are. This lovely picture appeared a little while ago, superimposition, of course, of two rhinoceroses. I think it's rather lovely. Well, these are some of the dilemmas, some of the myths, some of the difficulties. No answers, really, but a lot of questions. And I rather like this comment as well. So, perhaps I do feel mentally a little exhilarated, but not physically exhausted yet. Thank you for asking me to speak.